Dr. Ellen Wiebe is one of the country's first MAiD assessors and providers. Her patient-centered, compassionate, rights-based approach to end of life has provided solace to so many Canadians in the past 2 years. Ellen also guides practitioners with her expertise and has helped many, many practitioners navigate those early days of MAiD and how to bring this to their patients. On top of that, as if that's not enough, she's doing academic research and is a clinical professor in the Department of Family Practice at UBC, and she works in women's health at her own clinic.
I'm glad to be here tonight. I'm just going to go over one slide of stats and then talk about how we do our assessments and provisions. What I want you to focus here is Canada is in the middle. The first year, this is the percentage of all deaths. So approximately 1% of all deaths in Canada in the first year that it was legal were medically assisted. Now, if you look just beside Canada, you've got BC on one side, and you see that we were much higher, so there was a lot more percentage-wise deaths in BC than Canada. And this was, on the other side is Oregon, and it was their 20th year. So in our first year, we had almost twice as many by percentage than Oregon did in its 20th year. And then if you look next over in Netherlands and Belgium, we have similar laws, so we expect to eventually, and similar cultures, and we expect eventually to be in that range between 4 and 5% of all deaths. And then at the far end, you see IH, which stands for Island Health, and Vancouver Island had, in its first year, almost as many as Netherlands and Belgium. Very different. There's lots of reasons for that, but we're not going to talk about that. I'm going on to assessment, and I'm going to tell you that we don't use C14. Doctors and nurses don't use C14 to practice medicine. We use our licensing guidelines. So the College of Physicians and Surgeons licenses us, and we use their guidelines to practice by, so we can keep our licenses. And the next slide is the Professional Association, which is the Canadian Association of MAiD Assessors and Providers. And we set standards and guidelines for our members. So some parts are really easy, like are you over 18 and do you have Medicare? Voluntary is usually very easy because I would ask myself, who could possibly persuade this person to die when they didn't want to? And for example, nobody could persuade me to do so. So there's a lot of situations in which I don't worry about it at all, because I realize that there really is nobody who could do this to this person. But one of the situations that I am concerned about and watch very closely is when a couple wants to die together. And you can imagine that if you've been married for 60 years, you would be subject to pressure by your spouse if he said, yeah, I'd like to go together. And you said, I'm not quite ready. Something that we think about. So grievous and irremediable. Grievious isn't hard. Patient decides whether they're suffering or not, and not the doctor. So that's fine. I need to know about it. I record it, but it's not up to me to decide that she's suffering enough. It's up to her. But the irremediable, that I definitely do, and that's where I need to know that the patient has been offered the treatments that might make the condition better or at least the symptoms better. And they have to have been offered it. They don't have to try it. They have to understand it because they are allowed to refuse any treatment. Advanced state of decline is not really something that's very accessible. Where there's no sort of hard data on how to say somebody is advanced. It's sort of a combination of what the patient says and what the doctor looks at. So this is the hard one. And as Jay said, when I first met Robin, I refused her based on the fact that I felt that her death was not reasonably foreseeable. And then it was Jay who contacted me and said, so now that the AB decision has come out, are you going to change your mind about Robin? And I worked hard on this. I talked to people who knew AB, and the doctors who'd seen her, read the details of the decision, and then contacted Robin and said, I'm okay with it now. So what I personally use for my assessments of reasonably foreseeable is what the judge said in the AB versus Canada case. But other doctors and nurses don't. So one person will say, no, death is not reasonably foreseeable, and where I would say, yes, it is. And we each have to take this decision on our own. We have to take the risks of being, of complaints against us to our college, who of course can take our licenses away, or to the Crown, who could take our freedom away. Assessment of capacity is usually easy, but sometimes incredibly complex, because some of my patients have dementia, but they can still be competent. And they can be completely nonverbal and be competent, but I've got to figure it out, and it's not easy if I can't use words. And then, it's quite common when people have lost one function after another, lost their ability to do things, often lost people because they're aged and their friends and relatives have died. It's common to have depression. So then when is depression enough to interfere with capacity? It can be complex. The important thing is that the person must understand their condition, understand diagnosis, prognosis. They don't have to know the names, but they have to understand it. And they have to know what the alternatives are to an assisted death and make that choice, which is exactly what doctors do every day in every other kinds of medical decisions that patients have to make. If it's surgery, you have to know what the alternative to surgery is. If it's medication, you need to know what your alternatives are, and the doctor has to make sure that the patient understands what those are. And so it's the same as what we do every day. And I can tell you that saying no to Robin was one of the hardest things I ever did, and that's true of other people as well. As Jay said, just being in her presence, her suffering was so profound and so physical and in your face that it was just hard to be in the same room as Robin and feel her suffering. So let me talk about what it's like to provide. So this is what I've done over the last 2.5 years in assisted deaths. You can see that I've completed 126, and most of them were malignancies, but not by, it's a majority, but it's not a high majority. I've assessed twice as many as I provided for, and the people that I didn't provide for, whom I assessed, some of them, a few of them I assessed for another provider. So we have more assessors than we have providers. So I usually don't. It's usually the assessment is done by somebody who does assessments but not provisions. But I do assessments for other providers. So some of them are those. Some of them are people, it's just one of the most wonderful things about having MAiD in Canada is that somebody comes to me after they've had a horrible diagnosis. The cancer is back, it's in your bones and brain and lungs. The worst possible news they've just received. And they come to me when they're still feeling quite okay. And I say, yep, you're eligible. And they are so relieved and so grateful. And then they have the strength to face the next part, because they know that if it ever gets too bad, they've got a way out. And if it turns out that, the progression doesn't feel that bad, they just get kind of sleepier and sleepier, which is a lot of what cancer does to some people, then they're okay. One of my patients who booked her death, I came to see her, she was in the hospital, so I came to see her about 5 days before her booked death. And I said, just, wanting to know if you're still feeling the same as you was when we talked last. And she said, no, I've changed my mind. I was scared. I'm not scared anymore. I'm fine. And she actually died on the day she had booked her death. And you see that of the people that I refused, you can see them up there. Some of them were for capacity. Usually, when I'm called to see somebody, I get there and they're getting confused, like really confused, which often happens at the end of life. And I have to say no. Mostly for death not being foreseeable. And then another part of the law is that the condition cannot be primarily psychiatric. You're allowed to have a psychiatric condition as well if you fulfill all the other criteria. But the condition cannot be primarily psychiatric, which I've had to refuse. So once we've done the assessments, then we have this wonderful discussion. What does a good death mean to you? And almost everybody wants to have the pain under control, have the agitation, anxiety under control, not be in an emergency department with somebody vomiting beside you, and with the good people with you, your people you care for, and not some strangers or all alone. But the big difference for people, now that we have MAiD, is that it can be under their control. So what their choices are is, when would you like to die? And where would you like to die? And who do you want to invite to the death? And which method would you like? So I'm going to tell you a couple of stories. Carl, a 74-year-old in hospital, very close to the end. His pain was not under control, and he was struggling to breathe. He was suffering terribly. And next slide. His choice was that he could go to the palliative care unit and go under deep sedation, meaning put to sleep, and sleep out these last a few days that he had left. Or I could give him an assisted death. But the law says you must wait 10 days, and I would have to then expedite it on the basis that he was about to lose his capacity, which he would if he went upstairs. So I told him that he had a choice between a natural death, which he could have comfortably if he went upstairs and went to sleep with their drugs, or I could give him the medication that would end his life within minutes. And he said, that's not natural, being stuck up there with all those drugs pumped into me. You're just offering me a slow death versus a fast death, and I want the fast one. So it was he that chose that. And when I arrived the next day with my medication, his wife had climbed into bed with him, and his daughters were in the room, and there was laughter and there was tears, and he introduced me to his kids as his angel. So Rita wasn't in such bad shape. She was still in her own home. She couldn't breathe if she did anything. If she sat absolutely still and breathed her oxygen, she could breathe. If she tried to walk a couple of steps to the toilet, or a couple of steps between her bed and her chair, it would take her 10 minutes to recover. And she said, my life has shrunk, I'm ready to go, I've had a wonderful life. She was certainly not depressed. She was just finished. And she was not going into a care home. Next slide. So when I arrived on her day, I was told that her family had come and gone. She didn't want them there because she thought they would be too emotional. And she wanted her 3 best girlfriends who were there. And they all climbed into bed with her. She was wearing her best nightie. And they had champagne and they listened to opera, and one of them read poetry as she fell asleep and then died. Next slide. So a 48-year-old in a care home full of demented elders is a horrible tragedy. And he was finished. He could no longer sit in his chair, his electric wheelchair, and so he could no longer have even that little bit of independence, much less, he hadn't been able to feed himself, he hadn't been able to go to the toilet for a long time already. But for him, it was when he could no longer get in the chair and get out of that room. He was stuck in bed in that room for the rest of his life. So there were a few problems. His wife was furious and angry at me, said that I wasn't following proper process. The care home, it was there first, and that's really common. I've been to one care home after another, after another, after another. For each one, it was there first. And so he was one who had no suitable witnesses, and Dying with Dignity provided the witnesses. So when I arrived on the day, his dog was in bed with him, curled up against his legs, and his father was sitting beside him. And when Peter had a lovely smile on his face when he saw me coming. And after it was over, I gave my condolences to his father, and his father said, I was there at the beginning, and I was there at the end. Andy was in St. Paul's Hospital. St. Paul's is Catholic and refuses to have MAiD there. In fact, at first they were refusing to allow us to talk about MAiD there. But so I actually went there against the rules to talk to him. Now they, with a whole lot of publicity against them and meetings, they now allow me to go and talk. They give me special privileges for one day just to talk to one person, and then I no longer have privileges. So Andy's possibilities were that he was very ill and he might just die there and then, and that would be what happened. Or he might get well enough to go home, or he might not get well enough to go home and have to go to some kind of facility from the hospital. And he was very sure that he wasn't going to any facility. So luckily he survived that night and was able then to go home. And he waited until his sons could all come from away. And he, just like Rita, didn't want his sons there. He wanted friends who he thought wouldn't be so emotional. So Hannah Schaefer is the only one I'm giving you her real name, after Robin, because Jay gave you her real name, because she and her family really wanted her story told. She was the very first woman I helped, and she was the first person outside of Quebec in Canada who received an assisted death. So she had ALS, and when I met her, she was unable to speak. She had some movement in one thumb and one finger, her left ones, and that's it. And so she was able to use an iPad if somebody placed it just right, and she could move her finger. And for yes, she could give a thumbs up, just a tiny little thumbs up that we could all recognize. So huge problems. She was in Alberta and I was in BC, and she had to fly to Vancouver because there were no providers in Alberta. Now there are providers. What you'll see here is that so much has changed in 2 years. Now there are providers all over Canada, except, of course, some rural communities, smaller communities. Although the law had talked about, or the court decision, the Carter case, had exempted physicians, they hadn't done anything about pharmacists and nurses, and the colleges of pharmacists and nurses refused to let their members have anything to do with it, so I had no help. And then where were we going to do it? And the first funeral home said, absolutely not, and they weren't coming. And so we had, a lot of things that because it was the first case that didn't work. And in 2 years, a lot has changed. But Shanaaz, of course, is going to tell you what hasn't. So she came to my clinic, which is an abortion clinic, and that's where the St. Paul's patients come, too. It's interesting that St. Paul's gives them to me because I have a place that I can help them, so they're giving me people to take to an abortion clinic. Next slide. So the challenges we as providers still have is that there's geography problems with having to fly up to places to be able to provide. Facilities is my biggest thing. I hate the fact that there are still facilities that refuse. Sometimes the issue of colleagues disagreeing can be really tough because I need to get along with my colleagues, and yet I will accept somebody that they refuse, and it can be a problem. And then there's documentation. So there's lots and lots and lots of paperwork. That's, for one simple case, that one. And it's going to change at the end of summer, and it's going to be a lot worse because this went to a committee, and every person on the committee had ideas of what they wanted to know, and they added them all to what we already do. And so it's really onerous. And what really makes me angry about this is that this is a requirement under criminal law. If I don't submit the documentation that Health Canada is setting up, I am subject to criminal prosecution. And yet, the questions in those pages and pages and pages and pages and pages have to do with people's curiosity. And curiosity is lovely. I'm glad that people are curious. But they shouldn't make me have to do this on that basis. I mean, I absolutely expect to document and document well, and I will follow all the rules. But it seems to me that there should be, a reasonable amount of documentation that is required by law, and then extra when people want to do research. So, as I said, there's so many things about MAiD that is so wonderful. It provides this insurance policy that people talk about where they say, if it ever gets too bad, I know what I can do. The dignity in dying can be preserved. Unbearable suffering can end. And, the stories I told you, did you notice they were themselves at the end? They weren't somebody else. They were themselves still. And they were still socially interacting, which is not what happens in natural deaths. So just want to bring you back to Hannah and say we've had a lot of wonderful changes over the last 2 years since Hannah died, and we need some more. And that's why we got Shanaaz.